Hi everyone, in this module we are going to see about surgery related to appendix. So first we are going to see the basic anatomy of appendix. The most common portion of this appendix, this appendix is a blind ending tube from the cecum. So this can be most commonly in the retrocecal area, that is behind the cecum. That is the most common portion of this appendix. Second most common portion is the pelvic, that is towards the pelvic cavity. That the appendix, it goes towards the pelvic cavity. It locates at the 4 o'clock position. It locates at 4 o'clock position. This pelvic type is the most dangerous type. Apart from that, it can be either pre-ileal or post-ileal. If it is present before the ileum or if it is present anterior to ileum, it is pre-ileal. If it is present behind the ileum, it is called as post-ileal. Apart from that, it can be subcecal. If it is going at 6 o'clock position, from the cecum, it is going downwards, it is called as subcecal, 6 o'clock position. If it is near to the cecum, it is curving near to the cecum, it is called as paracecal. These are the positions of appendix. Apart from that, this appendix, it is supplied by appendicular artery. What is this appendicular artery? It is an end artery. It is a branch of ileocolic artery. Ileocolic artery or a branch this appendicular artery. This ileocolic artery, it is a branch of a superior mesenteric artery. This appendicular artery will be present in the mesoappendix. We will be separating this from the appendix before ligating the appendix during appendicectomy. Then, what is the cause for this appendicitis? This appendicitis, the most common cause is obstructive. Obstructive because of fecalith. That fecalith, if it goes and if it obstructs the lumen, that causes this appendix, followed by other non-obstructive causes. What is the earliest symptom? Earliest symptom of this appendix is pain. Pain usually in the umbilical region. It will be migrating towards the right iliac fossa. Patient will be telling that he or she is having had pain in the umbilical region. Now he or she is having pain in the right iliac fossa. So pain is the first symptom. Also there is a triad that is called as Murphy's triad. Murphy's triad. That number one is pain, migrating pain from the umbilicus to the right lower quadrant. Number one. Number two is after pain starts, patient will be presenting with fever. Patient can present with fever followed by nausea and vomiting. Apart from that, one more important symptom is anorexia. So in this Murphy's triad, the first symptom is pain followed by fever followed by nausea and vomiting. This is Murphy's triad. Whereas Murphy's sign, it will be seen in acute cholecystitis. Then, what are the signs of this acute appendicitis? Number one is Rovsing sign. These signs are repeatedly asked in NEET PG, so we have to remember this. Rovsing sign. What does that state is? If the patient is having the pain in the right lower quadrant on pressing on the left iliac fossa or left lower quadrant. So we know this is the large intestine. Large intestine, appendix will be in the right lower quadrant. So this is the descending colon, this is the transverse colon, this is the ascending colon. So what happens in this Rovsing sign is we are pressing in this left iliac fossa or left lower quadrant. Patient will have pain in the right lower quadrant. What happens is this bowel, it contains fecus. Fecus stool content will be inside. So if we press here, this fecus content, it will be moving towards the ascending colon, finally towards the cecum. Cecum என்ன இருக்கு? Appendix is there. Appendix is already inflamed. So if this fecalith, if it goes and if it touches this appendix, inflamed appendix, patient will be having pain in the right iliac fossa. So that is this Rovsing sign. So pressing on the left iliac fossa, patient will be having pain in the right iliac fossa, or pressing in the left lower quadrant, patient will be having pain in the right lower quadrant. That is Rovsing sign. Number two is tenderness of the McBurney's point. This McBurney's point is very much important. We must have studied in the final year. So what is this McBurney's point? It is a imaginary line. It's a point in the imaginary line. A imaginary line is drawn between the ASIS, anterior superior iliac spine, and umbilicus. This line is called as spino-umbilical line. anterior superior iliac spine, spino-umbilicus. Okay, it is drawn from the anterior superior iliac spine to the umbilicus. This imaginary line, it is divided into thirds. Okay, one third, one third, one third. Okay, so where is this neck bony spine located? It is located at the junction of median 2/3 and lateral 1/3 of this spino-umbilical line. What does this neck bony spine corresponds? It corresponds to the base of appendix. While pressing in this neck bony spine, if the patient is having pain, that is suggestive of acute appendicitis. Okay, so tenderness at the neck bony spine. This neck bony spine is important also for putting the incisions during surgeries. Okay, we will be discussing about that in further slides. Then pointing sign. What does this pointing sign describe? Patient B, we have to ask the patient to point where was the pain earlier and where is the pain now. Patient will be pointing towards the umbilicus. Umbilicusல வந்து முன்னாடி பெயின் இருந்துச்சுன்னு he or she will be telling. Now she will be pointing towards the right iliac fossa. Okay, so that is pointing sign. Asking the patient to point where was the pain and where is the pain now. Next is the Psoas sign. Okay, what is this Psoas sign? We have to ask the patient to, we can see in this image. Okay, so we can't ask him to hyperextend. We are hyperextending the hip. Okay, hip வந்து hyperextend பண்றோம், like that is shown in this image. Okay, we are hyperextending the hip. In that time, patient will be having pain. Okay, in the right iliac fossa, ஏன்னா because of the irritation of the psoas muscle. The psoas muscle ல போயிட்டு என்னது, inflamed appendix will be touching the psoas muscle. The psoas muscle, it is moved with the help of this hyperextension of the hip. In that time, if there is a pain, it is suggestive of retrocecal appendicitis. Psoas sign, it is suggestive of retrocecal appendicitis. Retrocecal appendicitis is the most common type of appendicitis. Next is the Obturator sign. What is this Obturator sign? We are doing the internal rotation of hip. அதாவது நீயை வந்து உள்ள கொண்டு போயிட்டு ஃபூட்டை வந்து வெளியே கொண்டு வரோம். Okay, in this image. Okay, foot is brought outside whereas knee is brought inwards. That is the internal rotation of hip. Internal rotation of hip causes pain in case of a pelvic type of appendicitis. Okay, it can also cause pain in retrocecal type of appendicitis. Most commonly it is suggestive of pelvic type of appendicitis. We have already seen pelvic type is the most dangerous type of appendicitis. Next is the Aron sign. What does this Aron sign stand for? Patient will be having pain or tenderness in the epigastrium. Okay, epigastrium அல்லது anterior chest on persistent pressure on the neck bony spine. When we are putting persistent pressure on the neck bony spine, patient will be having pain in the anterior chest or in the epigastrium. That is Aron sign. A for appendicitis. Remember that. Okay, already we have remembered A for Ameyans hernia. What is Ameyans hernia? Inguinal hernia with appendix as content is called Ameyans hernia. This Aron sign, it is also suggestive of acute appendicitis. AA, we can remember that. Okay, next is the Bastido sign. Okay, this is very rare but previously it is asked in NEET PG. Okay, so what is this Bastido sign? Patient will be having pain or tenderness in the right iliac fossa எப்போ on inflating the colon. Okay, colon வந்து inflated. Okay, inside the colon if you insert air, okay, rectum வழியா air insert பண்ணும்போது or inflate பண்ணும்போது patient will be having pain in the right iliac fossa. That is the Bastido sign. Okay, next is the 10 horn sign. Patient will be having pain on general traction of testis. Okay, testis 10 horn sign. Okay, T for T. Okay, 10 horn sign on general traction of testis. Patient will be having pain in the testis, right testis. On general traction of right testis, patient will be having pain in case of 10 horn sign. That is also suggestive of acute appendicitis. Next is, this slide is very much important. What is Alvarado score? Alvarado score, it tells us whether we can proceed with conservative management or we are going to go with surgery. Okay, that is Alvarado score. How are we going to remember that? We are going to remember with the mnemonic mandrels. Okay, mandrels. Okay, mandrels. M for migration of pain. Where does this pain migrate? It migrates from the umbilicus to the right iliac fossa. It is given 1 point. Then is next point is anorexia. You have seen anorexia is an important symptom of this acute appendicitis, பசியின்மை. Okay, that is anorexia. Next is nausea and vomiting. Okay, it is a part of the Murphy's triad. Next, T stands for tenderness in the right lower quadrant. Okay, that is very much important. So it is given 2 points. Next is rebound sign. What is this rebound pain? On pressing, patient will be having pain. On releasing, if the patient is having pain, that is called as rebound pain or rebound tenderness. That is also suggestive of this acute appendicitis. Next is elevated temperature. Okay, elevated temperature. அதாவது we are fever தான் elevated temperature னு சொல்லியிருக்காங்க. TREL, E for elevated temperature, that is fever. Next is leukocytosis. What is leukocytosis? Increase in the WBC count. That is leukocytosis. That is also very much important. So it is also given 2 points. Next is the shift of white blood cell count to the left. Differential count எடுக்கிறோம், அதில் it will be shifting towards the left. அதாவது immature cells towards அது shift ஆயிருக்கும். That is yes. Okay, so டோட்டலாக 8 தான் இருக்கு, but total points are 10. So ரெண்டு இதுக்கு 2 பாயிண்ட் கொடுக்க போகிறோம். ரெண்டு important thing. One is tenderness in the right lower quadrant. Number 2, increase WBC count. So இது எல்லாமே it is included in Mandrel score, that is Alvarado score. If the score is more than or equal to 7, we are going to go for appendicectomy. Either open or lap. Lap இருந்துச்சுன்னா lap போகிறோம், இல்லைனா emergency open appendicectomy we are going to proceed. Next, what is the investigation of choice? How are we going to radiologically diagnose this? Investigation of choice in case of a child. ஒரு child கொடுத்துருக்காங்க கொஸ்டினில் suggestive of acute appendicitis, அதுக்கு ஏத்தாப்புல பெயின் சிம்டம்ஸ் எல்லாம் ரைட் இலியாக் ஃபோர்ஸில் பெயின் சொல்கிறாங்க, ஃபீவர், வாமிட்டிங், இந்த மாதிரி ஒரு சிம்டம்ஸோட ப்ரெசென்ட் பண்ணுறாங்க அப்படின்னா we have to go with ultrasound. Whereas in case of adults it is CT. Okay, in case of ultrasound, in normal appendix it will be like a blind ending tube அப்படின்னு கொடுத்திருப்பாங்க. Normally if the diameter is less than 6 mm, it is a normal appendix. If the diameter is more than 6 mm, okay, இதில் பார்த்தோம்னா diameter is more than 6 mm. Also wall thickness increase ஆயிருக்கு. If it is more than 3 mm, it is suggestive of acute appendicitis. Ultrasound is the investigation of choice in case of a children, whereas CT is the investigation of choice in case of adults. Okay, so here we can see there is a dilated appendix in transverse section of CT. Also இதில் வந்து we can see there is a dilated appendix. உள்ள என்ன இருக்கு? There is a fecolith. That white color thing is a fecolith or appendicolith. Okay, next we are seeing a இது sagittal section. Okay, we are seeing a sagittal section. Here we can see appendicolith. Okay, two appendicolith, and the appendix also is dilated. Okay, so transverse section la theriyala appadina we can either go for coronal section or we can go for sagittal section. And the section la we can see this appendix. Yana appendix is not in a சிங்கிள் பொசிஷன். ஓகே, எப்போவுமே ரெட்ரோசிக்கலாக இருக்க போகிறதில்ல, எப்போவுமே பெல்விக்காக இருக்க போகிறதில்ல. அது வந்து எதர் இப்படி இருக்கும், இப்படி இருக்கும், எந்த பொசிஷன் வேணால் இருக்கலாம். ஸோ ட்ரான்ஸ்ஃபர் செக்ஷனில் ஒழுங்காக தெரியலனா we can go for என்னது coronal section or we can go for sagittal section of CT. அதை வச்சு we can diagnose this acute appendicitis. Next is how are we going to treat this patient? We already said we are going to go for appendicectomy. Okay, now we are going to see about open appendicectomy. Open appendicectomy la most common incision வந்து என்ன incision na இவ்வளவு நாள் ஃபாலோ பண்ண incision is McBurney's incision. McBurney's incision, where do we put this incision? Okay வா, அதே McBurney spine தான். Where is this McBurney spine? It is at the junction of medial 2/3 and lateral 1/3 of the spino-umbilical line. McBurney spine எடுத்துட்டு அதில் we are going to do a put an incision perpendicular to the McBurney spine. Okay, and the incision oda length la upper it has to be 1/3 and lower it has to be 2/3. This is the McBurney's incision. McBurney's incision, it is put perpendicular to that of the spino-umbilical line at the McBurney spine. Okay, here it is also called as gridiron incision. Okay, gridiron incision. Here we are not going to cut the muscles, we are just going to split the muscles, and we are going to go inside. So that is called as gridiron incision, McBurney's or gridiron incision. So what is the complication of this? What is the complication of cutting at the McBurney's and in the McBurney's perpendicular இந்த இடத்துல இன்சிஷன் போட்டா என்ன நடக்கும் அப்படின்னா we can may or may not injure the ileohypogastric nerve. This ileohypogastric nerve, it supplies the abdominal muscles. So this ileohypogastric nerve injury can cause direct inguinal hernia. Okay, so right appendicitis right acute appendicitis க்கு போடக்கூடிய McBurney's incision or this gridiron incision, it can cause another, it can cause ileohypogastric nerve injury that can cause direct inguinal hernia. Next is a modification of this, that is a Rutherford Morrison incision. What the inge enna difference na, there we have split the muscles. Now we are going to cut the muscles. Okay, muscles are cut panna porom, internal oblique and transverse muscles are cut. Okay va, cut panni we are going to extend the incision upwards. Okay, upwards and laterally it is extended. Okay, so where it can be used, it is used in case of paracecal or retrocecal. Okay, retrocecal enga irukum, behind the cecum இருக்கும். ஸோ இந்த இன்சிஷன் பேஸ் ஆஃப் அப்பெண்டிக்ஸ் தான் மெக்பர்னி ஸ்பைனில் இருக்க போகுது. பேஸ் ஆஃப் அப்பெண்டிக்ஸ்னா கரெக்டாக நார்மலான ஒரு இதில் சீக்கத்துக்கும் இதுக்கும் நடுவில் இந்த இடம் தான் நமக்கு வந்து மெக்பர்னி ஸ்பைனுக்கு கரெக்டாக இருக்கும். ஆனால் இட் இஸ் பிஹைண்ட் தி அப்பெண்டிக்ஸ், பிஹைண்ட் தி சீக்கம். ஸோ we have to extend the incision. So muscle cut பண்ணி we are going to extend the incision, that is called as Rutherford Morrison's incision. Okay, it is extended upwards and laterally. It is useful in paracecal and retrocecal type of appendicitis. இதில் கண்டுபிடிக்க முடியல, சாதா இன்சிஷனில் கண்டுபிடிக்கணும்னா we can extend the McBurney's incision. Okay, now because of the நிறைய பேர் வந்து அந்த இன்சிஷன் வெளியே தெரியக்கூடாது ஓகேவா. ஸோ they have come with another incision, that's a Lange incision. Lange incision, it is put along the Langer's line. Okay, incision is put in the direction. Okay, okay, it is put here. Okay, along the Langer's line it is put. It has been put so that patient வந்து பிக்கினி போட்டால் அந்த பிக்கினிக்குள்ளே வந்து இது கவர் ஆகிற மாதிரி போடுற மாதிரி இன்சிஷன். ஓகே, ஸோ தட் இஸ் திஸ் Lange incision. ஓகே, இட் இஸ் காஸ்மெட்டிக்கலி பெட்டர் கம்பேர்ட் வித் தட் ஆஃப் திஸ் McBurney's incision. ஸோ Lange incision, இட் இஸ் ஆல்சோ எ மசில் ஸ்பிளிட்டிங் இன்சிஷன் தான். ஒன்லி மசில் கட்டிங் இன்சிஷன் இஸ் Rutherford Morrison's incision. You must not forget this. Then if it is a complicated appendicitis, appendix perforate ஆயிருக்கு, ரொம்ப காம்ப்ளிகேட்டடாக இருக்குது, பெரிட்டோனைட்டிஸ்லாம் இருக்குது அப்படின்னா we are going to go for a lower midline incision. Laparotomy incision போடுற மாதிரி lower midline மட்டும் we are going to put an incision. That is done for any complicated appendicitis. Okay, perforation, அதுக்கப்புறம் வந்து fecal and peritonitis அந்த மாதிரி வேற காம்ப்ளிகேஷன்ஸ்லாம் இருக்குது அப்படின்னா வாஷ் எல்லாம் கொடுக்கணும். அப்பெண்டிக்ஸ் ஈஸியாக கண்டுபிடிக்கிறதுக்காக we are going to go for a என்னது lower midline incision. Okay, what is the most common complication of this open appendicitis? It is wound infection. Okay, wound infection na most common complication. Apart from that, gridiron incision la or complication பார்த்தோம். Because of the injury to the ileohypogastric muscle, patient is going to have a direct inguinal hernia. Next is a கொஞ்சம் காம்ப்ளெக்ஸான இது. If the base is gangrenous. Okay, போகிறோம் பேஸை வந்து கண்டுபிடிக்கிறோம், ஆனால் பேஸ் கேங்க்ரினஸாக இருக்குது. அப்போ கட் பண்ணிட்டு லைகேட் பண்ணிட்டு நார்மல் அப்பெண்டிசைட்டிஸ் மாதிரி வந்துடலாமா? வரக்கூடாது. We have to proceed with the right hemicolectomy. ஸோ கொஸ்டினில் கேட்கலாம், அக்யூட் அப்பெண்டிசைட்டிஸ் கண்டுபிடிக்கிறோம், உள்ளே போகிறோம், உள்ளே போனால் பேஸ் வந்து கேங்க்ரினஸாக இருக்குது. How are we going to proceed? We are going to do a right hemicolectomy. Okay, suppose உள்ளே போகிறோம், right iliac fossa பார்க்குறோம், appendix நார்மலாக இருக்குது. What are we going to do? அதை மட்டும் எடுத்துகிட்டு வந்துடலாமா? No, we have to see for Meckel's diverticulum. Okay, this Meckel's diverticulitis, it is a differential diagnosis for acute appendicitis. So we have to search up to 60 centimeter, அதாவது 2 feet. Okay, this will be rule of 2 படிச்சிருப்போம்ல Meckel's diverticulum. It will be 2 feet from the ileocecal junction. So அது வரைக்கும் போயிட்டு அங்கே ஏதாவது ஒரு diverticulum இருக்கா அப்படின்னு சொல்லிட்டு we have to search for. Okay, so Meckel's diverticulitis is a differential diagnosis for this acute appendicitis. Okay, so suppose appendix நார்மலாக இருக்குன்னா we have to search up to 60 cm from the ileocecal junction. எங்க small intestine search பண்ண போகிறோம், ileum search பண்ண போகிறோம். Okay, then What happens if the patient presents with appendicitis during pregnancy? Can we go for conservative management? No. This appendicitis, it is the most common non-obstetric emergency during pregnancy. We can't put conservative management. We are going to go for lap appendicectomy in all the trimesters. In the trimester patient vandalum, either first, second or third, we are going to go for lap appendicectomy. Here there is a test that is called as Alder's test. It is used to differentiate between a gynecological cause or non-gynecological cause. Okay, so usually in case of an pregnant woman, this appendicitis pain won't be in the neck bony spine. It will be little bit higher up. Okay, so okay, adu thani. Okay, also what does this Alder's test do is we have to go and palpate the point where the patient is having the maximum tenderness. Okay, adha poi we are going to give a pressure. Okay, adala pressure kodukku porom. Epo patient is asked to lie down in a supine position. Okay, now we are going to palpate in the area where the patient is having the maximum tenderness. Okay, adala palpate panni vechikrom. Now we are asking the patient to lie down on her left. Okay, left lateral position la padikka solrom. We are not taking the hand. Okay, now if the patient is having the same pain, it is suggestive of appendicitis. If the patient's pain getting reduced or pain illamale poichu abdina, that is suggestive of some gynecological or some obstetric cause. Okay, because appendicitis, it is attached to the retroperitoneum. Patient left la thirumbodhu appendix வந்து position மாற போறது இல்ல, அங்கேயே தான் இருக்க போகுது. So that is suggestive of appendicitis. Patient left la thirumbodhu gynecological cause அல்ல obstetric cause எதாவது இருந்துச்சுன்னா that particular segment வந்து அந்த பொசிஷனை விட்டு மாறிடும். அதனால பேஷண்டோட பெயின் வந்து செட்டில் ஆயிரும் அல்லது பெயின் வந்து ரெடியூஸ் ஆயிரும். That is suggestive of gynecological or obstetric cause. This test is called as Alder's test. Okay. Next, what is the differential diagnosis? Okay, we have seen already one differential diagnosis, Meckel's diverticulitis. But the most common differential diagnosis is mesenteric lymphadenitis. நிறைய பேஷண்ட் ரைட் இலியாக் ஃபோஸா பெயினோட வருவாங்க, யங் பேஷண்ட். ஓகே, ஒரு 10 to 20 இயர்ஸில் இருப்பாங்க. அல்ட்ராசவுண்ட் எடுத்து பார்த்தோம்னா மேஜர் அவங்களுக்கு வரக்கூடியது mesenteric lymphadenitis. ஓகே, இந்த சிப்ஸு அந்த மாதிரி ஐட்டம்ஸ் அதிகமாக சாப்பிட்றதுனால அந்த இன்ஃப்ளமேஷனால் வர்றது தான் இந்த mesenteric lymphadenitis. Previously asked question, what is the causative agent for this mesenteric lymphadenitis? That is Yersinia enterocolitica. Okay, Yersinia enterocolitica. Next is the appendicular lump. Okay, suppose வந்து பேஷண்ட் ப்ரெசென்ட் பண்ணுறாங்க, ஆனால் வந்து ரொம்ப நாள் ஆயிடுச்சு, லேட்டாக ப்ரெசென்ட் பண்ணுறாங்க, அல்ட்ராசவுண்ட் எடுத்து பார்க்குறோம் அல்லது சிடி எடுத்து பார்க்குறோம், இட் இஸ் சஜஸ்டிவ் ஆஃப் அன் அப்பெண்டிகுலர் லம்ப். ஆர்எல்ஸ் பால்பேட் பண்ணி பார்க்குறோம், ரைட் இலியாக் ஃபோஸால் ஒரு ஸ்வெல்லிங் இருக்குது. ஓகே, அது வந்து அப்பெண்டிகுலர் லம்ப்னு சொல்லிட்டு கன்ஃபார்ம் பண்ணுறோம். How are we going to manage? Will we proceed with surgery immediately? No, we are going to manage the patient conservatively. Okay, what does this regimen called? It is called as Ochsner-Sheren's regimen. We are going to monitor the patient. If the patient pain எல்லாமே செட்டில் ஆயிடுச்சு அப்படின்னா ஓகே. If the patient is going unstable அல்லது அந்த பெயின் செட்டில் ஆகலை அப்படின்னா we are going to proceed with surgery. Okay, what all the things we are going to monitor? We are going to monitor the size of the swelling. Okay, number one. Then we are going to monitor the vitals, heart rate, pulse rate, respiratory rate, BP. Then we are going to monitor the temperature, also the pain. Okay, இதெல்லாம் மானிட்டர் பண்ண போகிறோம். Okay, next we are going to keep the patient in NPO. We are going to give the IV fluids. அப்புறம் வந்து இன்ஃப்ளமேஷனுக்கு we are going to give, இன்ஃபெக்ஷனுக்கு we are going to give antibiotics, பெயினுக்கு we are going to give analgesics. We are going to monitor the size. If the size increases, number one. If the heart rate increases, number two. If the blood pressure decreases, number three. If the temperature increases, number four. If the pain increases, இதெல்லாம் suggestive of என்னது, either patient can go for an appendicular abscess அல்லது appendix ஏதாவது rupture ஆகிருக்கலாம், அந்த மாதிரி நமக்கு வந்து சொல்லுது. ஓகே, ஸோ in that condition we are not going to proceed with conservative management. We are going to do a acute appendicectomy. Okay, we are going to open. ஏன் இந்த appendicular lumpல வந்து எமர்ஜென்சியாக appendicectomy பண்ண மாட்டோம் அப்படின்னா, this appendicular lump how it is formed? It is formed such that appendix வந்து perforate ஆகி இதாகக்கூடாதுன்னு சொல்லிட்டு the policeman of our body, our omentum, அங்கே பக்கத்தில் இருக்கக்கூடிய சீக்கம், இலியம் எல்லாம் சேர்ந்து அந்த அப்பெண்டிக்ஸை கவர் பண்ணி இருக்கும். ஸோ இப்போ போய் அதை அப்பெண்டிக்ஸை கண்டுபிடிக்க போகும்போது ஒவ்வொன்றா நம்ம ரிலீஸ் பண்ணும்போது we can iatrogenically cause a perforation. So better to go for a conservative management, and later after 6 weeks, approximately 6 weeks, we can go for appendicectomy. That is called a interval appendicectomy. Okay. பட் சப்போஸ் இஃப் இந்த காம்ப்ளிகேட் ஏதாவது ஆச்சு, சொல்லிங்கோட சைஸ் இன்க்ரீஸ் ஆச்சு, பெயின் இன்க்ரீஸ் ஆயிடுச்சு, டெம்பரேச்சர் இன்க்ரீஸ் ஆயிடுச்சு, ஹார்ட் ரேட் இன்க்ரீஸ் ஆயிடுச்சு, பிளட் ப்ரெஷர் கம்மி ஆயிடுச்சு அப்படின்னா we have to suspect an appendicular abscess and we have to open பண்ணி either we are going to drain the abscess, அப்பெண்டிக்ஸை கரெக்டாக கண்டுபிடிக்க முடிஞ்சதுன்னா we can go and we can also do an appendicectomy. இல்லை அப்பெண்டிக்ஸை கண்டுபிடிக்க முடியல, அப்பெண்டிக்ஸ் ரொம்ப ஒட்டி இருக்கு அப்படின்னா we can wait for 6 weeks, then we can go and do an interval appendicectomy. Okay. Next is a perforated appendix. What is the most common cause for a perforated appendix? It is Bacteroides fragilis. Suppose question in the option illa abdina, we are going to go for an Escherichia coli. Escherichia coli the second most common cause for a perforated appendix. Then next we are going to go for appendicular tumors. Okay, appendicular tumors. What is the most common appendicular tumor? That is a carcinoid. Carcinoid is the most common appendicular tumor, whereas most common site for carcinoid is also appendix. Okay, what is the most common malignant tumor of appendix? It is mucinous adenocarcinoma. Mucinous adenocarcinoma, it is the most common malignant tumor of appendix. So what is this carcinoid? The most common site of carcinoid is appendix. Appendix la enga most common ah irukum in the tip of the appendix. That is the most common site. Where does they arise from? They arise from Argentaphyid cells. Okay, Kulczycki cells. Okay, also it is called as Argentaphyid tissues. Okay, adalanda these carcinoids are getting arising. So what is this carcinoid syndrome? Okay, there will be an excess production of 5-hydroxytryptophan, அதாவது serotonin, in this carcinoid tumors. But what happens is this liver, it will be excreting this 5-hydroxytryptophan. In case of liver metastasis, okay, carcinoid associated with liver metastasis, in that conditions enna agum appadina liver cannot metabolize or liver cannot excrete this serotonin. So the serotonin will be in excess in the blood, and that can cause bronchospasm, that can cause sweating to the patient, that can also cause flushing. Okay, next important is it can also cause a syndrome that is called as Hedinger syndrome. This syndrome is in Bailey and Love. Maybe it can be asked. Okay, what is this Hedinger syndrome? It is a complication of this carcinoid syndrome. What is that? It is a restrictive cardiomyopathy, something related to the heart. Restrictive cardiomyopathy secondary to a fibrotic right side valvular heart disease. Okay, right side valvular heart disease cause பண்றாங்க நடக்குது in carcinoid. அது என்ன காஸ் பண்ணுது? It is causing a restrictive cardiomyopathy. This is called as Hedinger syndrome. Okay, Hedinger syndrome. Then what are the investigation? Investigation is we have to do a 24-hour urine test பண்ண போறோம். அதுல 5-hydroxy indole acetic acid is tested. Okay, this is if it is increased, that is more specific for this carcinoid tumors. Okay, then in blood we have to see the chromogranin. Okay, chromogranin A, it is checked in the blood. Then what is the imaging investigation of choice? It is serotonin receptor scintigraphy. It is also used in pancreatic endocrine tumors. This serotonin receptor scintigraphy is used. Then how are we going to manage these patients? Okay, suppose if the tumor is close to the tip, we have seen tumor is most commonly towards the tip la dhaan irukku, or if the tumor is less than 2 cm, we can go for a simple appendicectomy. Okay, tip la irukku tumor, or if the tumor is less than 2 cm, we can go for simple appendicectomy. Adha taandi if the tumor is in the base of appendix, or if the tumor size is more than 3 cm, we have to go for a hemicolectomy. Okay, hemicolectomy. Okay, one more thing is if the lymph nodes are involved, if the cecal walls are involved, we have to go for a right hemicolectomy. So only criteria for a appendicectomy in case of a carcinoid tumor is if the tumor has to be less than 2 centimeter, also tumor has to be in the tip of the appendix. If the tumor is in the base of appendix, if the tumor is more than 2 centimeter, if lymph nodes are involved, if cecal wall is involved, we are going to go for a right hemicolectomy. Next, last topic is a pseudo myxoma peritoni. Okay, what is this? It is a mucinous deposits in the peritoneum. We have seen what is the most common type of malignant tumor in case of appendix. It is a mucinous adenocarcinoma. This mucinous adenocarcinoma, if it undergoes a perforation, okay, that can lead to a pseudomyxoma peritoni, that can deposit the mucinous tissues in the peritoneum, causing this pseudomyxoma peritoni. So this mucinous adenocarcinoma of appendix is the most common primary that is leading to this pseudomyxoma peritoni. How are we going to manage? We are going to manage with a cytoreductive surgery. We are going to do a right hemicolectomy. We are also going to remove the peritoneum. And then the peritoneum that is having this mucinous deposits, that is removed. Regional peritonectomy is done. Then omentum that is involved is also removed. Ellame remove pandrom. That is the cytoreductive surgery followed by HIPEC. What is this HIPEC? It is a hyperthermic intraperitoneal chemotherapy. Okay, hyperthermic, increased temperature la we are going to instill the chemotherapy directly into the peritoneum. Either it is done using mitomycin C or it is done using oxaliplatin. That completes this appendix. So we have 2 questions for you. Okay, the questions for answer to be posted in the comments. Okay, clean, contaminated, dirty. In the Mari, we are having 4 types of wounds. This emergency appendicectomy comes under which type of wounds? Number 1. This elective or interval appendicectomy comes under which type of wounds? These 2 questions are for you to be posted in the comments. Thank you. Like, share and subscribe for more contents. Thank you.